Hi guys, welcome back to BROMED Lectures. In this video, we're going to be addressing thyroid function tests. So in this video, we're going to talk about the specifics of the thyroid function tests and what you should be concentrated at when reviewing these tests. But as a reminder, let's begin with how this system works. So the first thing that you need to notice and to recognize is that all of these are in function of an axis, an endocrinologic axis that is actually well controlled by the hypothalamus, the anterior pituitary, and the gland itself, okay? So as a reminder, the TRH, thyroid-releasing hormone from the hypothalamus, stimulates the anterior pituitary for you to generate TSH, and TSH is the one regulating the gland itself with promoting all of the iodine processes, the production of the hormones, and actually the secretion of the hormones from the thyroid gland itself. And now these thyroid gland hormones, the T4 and T3, are the ones that are going to inhibit the axis right in this point at the anterior pituitary. And so keep this in mind for this information. And so let's review this as a matter of rules that you need to follow when you're seeing someone's thyroid function tests, okay? So the first rule number 1, is going to be this one. Always have a TSH to review these tests. This is the most sensitive test, this is your screening test, and this is the one telling you where the diagnosis is leading, okay? Always have a TSH. Then rule number 2 is always check free T4 levels. This is because the total amount of hormone or the total measurements of hormone may be altered by the thyroid binding globulin. So always check and always diagnose in the basis of the free levels of hormone, okay? So some examples of these are here. First of all, if you have a pregnancy or oral contraceptives or hormonal replacement therapy, or if you have high estrogen states, then you will make more thyroid binding globulin. This is going to increase the total amount of hormone that you have, but if you are a normal person, then you're going to have normal free T4. And notice that I mentioned that it is if you are a normal healthy person, because if you have any hypothyroid state, non-diagnosed or already diagnosed, and you develop into one of these states, then you're going to have to replace the hormone because the gland is not going to be able to keep up with increase of thyroid binding globulin. This is the reason behind adding an increased dose of thyroid hormone for the pregnant patients and for the patients receiving these types of treatments. Now, nephrotic syndrome and androgen states, see how estrogen states increase thyroid binding globulin, and androgen states or increased androgen hormone is going to decrease the thyroid binding globulin, such as the nephrotic syndrome, because you're losing the proteins, right? So this one's going to decrease the total amount, but if you are a healthy person, you're also going to keep up with normal free thyroid hormone levels, right? So keep this in mind because you may be asked questions about these associations, okay? Now, the third rule, this was your number 2, to always check the free T4, and your number 3 rule is going to be this one right here. These are listed as a matter of examples, but it's your radioactive iodine uptake. And this one right here is telling you exactly how the gland is working, okay? So let's review these examples. If you have low TSH, right? This is telling you that TSH is not being produced, and then you perform your free T4 and T3, and you notice this, that they're increased, right? And so this one is telling you that the T4 and T3 are inhibiting the access by a negative loop feedback to the TSH, right? But if you add to this information that you have an increased radioactive iodine uptake, then this is telling you that it is the gland itself that is producing these hormones, right? So you may start wondering about the differential diagnosis of primary hyperthyroidism, right? The next one, You have also a decreased TSH, an increased T4 and T3, same as the example right here, but now you have a decreased radioactive iodine uptake. This is telling you that this is not the gland, the one that's causing these hyperthyroid states, so you maybe ask yourself if the patient has either factitious, getting exogenous thyroid hormone, or if there has been an inflammation with destruction of the gland, some thyroiditis, that is leading to this hyperthyroid state momentaneously. Now, this one right here is pretty particular. You have low TSH with low T4 and T3, and by itself, it's actually leading you to think that there's no correlation, right? Why with a low thyroid state, like low thyroid hormone state, would lead to this low TSH? And then you have this one right here, and this is telling you that none of the axis is working, right? So you may suspect that this patient has either secondary, it is the TSH not working, or tertiary, it is the hypothalamus, right? Hypothyroidism. So you measure these hormones, the TRH, the TSH again, and then you make your diagnosis of what is the cause of the hypothyroidism. And then this one right here is telling you increased TSH with a decreased thyroid hormone. This is telling you that these hormones are not inhibiting the TSH, and that's why it is up, right? But if you have the radioactive iodine uptake being low, then now you know it is the gland itself that it's not working, and so you may think about primary hypothyroidism, right? Hashimoto or any other diagnosis for these conditions. And so your fourth and last rule is going to be the next one. After you elucidate these things, you may come into a realization of where your diagnosis is at, where your patient is at, and now you want to add some more specific tests. Rule number 4, the specific tests for some conditions. And this is going to be the last part of your diagnosis algorithm. First one, antibodies. There's some specific ones like antimicrosomal, antithyroglobulin, and these ones are for Hashimoto. They can appear in other conditions, in other thyroiditis, in Graves' disease, for example, but are more specific for Hashimoto. Particularly if you have a primary hypothyroidism diagnosis and then you perform this, boom, you have your diagnosis is Hashimoto. Next, thyroid stimulating immunoglobulin. This one's pretty specific. This is an immunoglobulin that stimulates the thyroid gland itself, and this one's called Graves' disease, right? So this is telling you your diagnosis. And next, the thyroglobulin. This one's more specific for certain subspecialties in thyroid pathologies. Cancer as a follow-up or factitious may lead you to hint you if this one's low or if there's a reoccurrence of these volumes in the serum, then you have a diagnosis of cancer or some other pathology specific for these conditions. So those are your rules: TSH, free T4 levels, add the radioactive iodine uptake to know how is the gland functioning, and then number 4, get to the specifics with other tests. That's going to be for this section.